Good afternoon. So my discussion would be on a rare variant of cancer, that is penile cancer. So I'll be discussing about a prospective study of chemoradiotherapy as primary treatment with locoregionally advanced penile cancer. So why was the study undertaken? So penile cancer is a rare malignancy which has an incidence of 0.9 to 2 per 100,000 population. This is basically Western data. In Africa and South Asian regions, this incidence is slightly higher. Now, early stage penile cancer is treated effectively with surgery, that is penectomy plus or minus ILND or brachytherapy. Unfortunately, in our country and many other countries in Asia and Africa, a large percentage of patients present at local regionally advanced stage. This may be due to social stigma or lack of awareness. Surgical removal of large multiple pelvic lymph node metastases as well as large primary tumors lead to poor clinical outcomes. So if you look at the 5-year survival rates, in lymph node negative patients, it's over 70%, but in lymph node positive patients, it's down to 30%. So neoadjuvant cisplatin-based chemotherapy followed by surgery is the most studied as well as recommended strategy in these subset of patients. So neoadjuvant chemotherapy, how effective is it? So I've just quoted a recent systematic review and meta-analysis of NACT in locoregionally advanced penile cancers. You can see from the forest plot, the overall response rates is about 57%, but the PATH-CR rates is only about 7 to 11% across studies. Most patients in the meta-analysis included the TIP regimen, and the occurrence of grade 3 or higher toxicity was in 22% of patients. So there is an unmet need for better tolerated and effective treatment option for locoregionally advanced penile cancer. So now we come to chemoradiotherapy. As why was chemoradiotherapy chosen for the study? Chemoradiotherapy has been shown to be effective in squamous cell carcinomas of other sites, including head and neck, cervix, and anal canal. Small retrospective studies and case series, they have shown some good response rates to chemoradiation. Currently ongoing international penile advanced cancer trial, that's the IMPACT trial, is the phase 3 trial that is also evaluating role of chemoradiation in the neoadjuvant as well as adjuvant setting. So chemoradiation previously has not been prospectively evaluated, and therefore this study is important. Coming to the study proper, the population included in the study included locally advanced penile squamous cell carcinoma. Locally advanced was defined as a large or inoperable primary tumor, that is T3 or T4, palpable lymph nodes more than 3 centimeters in diameter, fixed nodes or suspicion of extranodal extension on imaging, as well as pelvic nodal involvement. The intervention used in the study was chemoradiation. So if you look at chemoradiation, they went up to a dose of almost 60 gray in 33 fractions. This included treatment to the primary disease as well as elective nodal region, and they gave concurrent chemotherapy with mitomycin and capecitabine. The comparator arm, there was no comparator. It's a single arm prospective design. The primary endpoint of the study was 1-year PFS. The secondary endpoints included 2-year PFS, 1 and 2-year OS, response rates, and toxicity. Patients were followed up for a period of 2 years. Now, the sample size was derived from previous historical studies, that is NACT followed by surgery data, assuming an alpha of 0.05 and beta of 80%, 33 patients were to be included. So totally 33 patients were recruited. This is basically the patient characteristics. The important point is most patients included were PS0 or 1. Clinical T2 or T3 constituted almost 67% of patients. Clinical N3 was there in more than 80% of patients. 60% were HPV negative, and chemoradiation included radiation to the lymph node region in all patients except 1. So what was the staging? What was the intervention and follow-up in the study? All patients were initially staged with FDG PET-CT, and if feasible, the primary disease was surgically resected before chemoradiation was done. As previously mentioned, radiation was given up to a dose of 59.4 gray, with elective nodal irradiation as well up to 50 gray. The concurrent chemo was mitomycin C on day 1, and capecitabine concurrently with radiation. All the patients were treated with simultaneous integrated boost volumetric arc therapy. After chemoradiation, the first evaluation with imaging was done at 6 weeks. And if residual was present at that point, salvage surgery was attempted. PET-CT and clinical examination with or without FNAC was continued 3 monthly till 2 years. And in patients with recurrence on follow-up, salvage surgery was offered. So if you look at compliance and toxicity profile, 32 patients completed treatment. Only 1 patient discontinued treatment due to skin toxicity. The most common side effect was dermatitis. This was followed by pain and diarrhea, but most of these side effects were mild. Protocol deviation was documented in only 3 patients, and grade 3 toxicity was documented in 1/3 of patients. So if you look at response rates, as per the PET-CT done, either partial response or complete response was documented in 72% of patients. So these patients did respond to chemoradiation. But if you look at the disease status at last follow-up, only 12 patients remained without disease. That is, only about 35 patients remained without disease. So the disease seems to respond to chemoradiation, but it recurs earlier. So if you look at the survival graphs, just to summarize, 1-year PFS was only 34%, 2-year PFS was 31%, the survival was 71% at first year and 46% in the second year. So if you look at the patterns of recurrence, both in-field as well as distal recurrences did occur. Interestingly, out of 23 patients who recurred or progressed, 15 had in-field failure. That is, wherever radiation was given, the recurrences occurred in the same region. So this actually suggests that probably the radiation was suboptimal. So what do we do about that? So only hypothesis can be generated. A recent concept of genomic adjusted radiation dose is coming up. Maybe that would reduce the chance of in-field recurrence. Just a word about the IMPACT trial. This is an ECOG actin group trial. It's a phase 3 trial recruiting for locally advanced penile cancer. It looks at 2 key questions. Before surgery, does NACT help or NACTRT help? And after surgery has been done, does pelvic lymph node dissection with adjuvant chemoradiation help, or only chemoradiation helps in high-risk patients? The primary endpoint of this trial was OS. The sample size initially was 400. It had to be revised to 200. Accrual till date is only 100 patients. So with this, I'd like to conclude. So primary chemoradiotherapy has been attempted for the first time in a prospective basis. Response rates are good, but overall PFS is continues to be poor. Thank you.